Good afternoon, everyone, and welcome to today's webinar, Crisis Prevention and Support, an overview of START Services New Jersey, a program through YAI. Today's webinar is being hosted by the Rutgers Community Living Education Project, often referred to as CLEP. My name is Melanie McGacken, and on behalf of the CLEP team, I would like to thank you for joining us today. At CLEP, we work alongside individuals with intellectual developmental disabilities, their families, and the professionals who support them to explore all opportunities in community living. Through education, training, and resource sharing, we promote person-centered lives filled with choice, opportunity, and meaningful community connections. We're excited to share information about START, Systemic Therapeutic Assessment, Resources, and Treatment, a specialized no-cost program designed to support adults aged 21 and older with intellectual and/or developmental disabilities who have a complex behavioral or mental health need and are eligible for New Jersey's Division of Developmental Disability Services. Whether you are a family member, caregiver, advocate, or community partner, today's session will provide an overview of how START works collaboratively with existing supports to help prevent crises, reduce the need for hospitalizations, and promote stability and success in home and community settings. We encourage you to submit questions throughout today's presentation using the chat or Q&A feature, and we will do our best to address as many questions as possible during the discussion period at the end of today's webinar. And by all means, feel free to introduce yourself using that chat section. And share any resources that have been beneficial to you or the ones that you support. So often we're learning from each other during these sessions. At this time, I'd like to hand the virtual microphone over to today's presenter, Stephanie Farris, who is being joined by Dr. Jackie Palladino. Stephanie will introduce herself and guide us through today's session. Stephanie, welcome.
Thank you so much, Melanie. Thank you, everyone. Good afternoon, and I'm so glad everyone is here today. I'm very excited to share some information about our program. We are a relatively new program in the state. We're still under program development and implementation. So we have been operational for a little over a year now. Currently, we are serving 40 participants. We do have a max capacity of 100 to 125. And before we get into the nuts and bolts of it, let's just have a quick overview. As Melanie said, START stands for Systemic Therapeutic Assessment, Resources, and Treatment. And what that actually looks like in practice is we are a collaborative and consultative service. What we are not is direct care. So what we do is we work, instead of directly with a participant, we work with everyone in their circle of support. The philosophy behind START, and START is a national model. We've been around since the late 80s, founded by Dr. Joan Beasley, and we are currently in 35 states with our corporate headquarters as part of the University of New Hampshire's Institute on Disability, and they had taken over the corporate spearhead in 2009. So what we'd like to do is work with everyone's system. That's the primary caregiver, that could be a community resident, the support coordinator, a guardian, day program, pre-voc, anyone involved in that person's system of care. And we want to bring the system together so we can all communicate better, communicate consistently, and have the same message when caring for the participant. The philosophy behind that, is that if the system communicates better and more effectively, then the participant having challenges should see a reduction in both the frequency and the severity of those challenges. So everybody that we work with within that system is a partner. START only works if we all are collectively engaged and we all have buy-in and we all want the same outcomes. And that's a moving target. We can actually shift outcomes as we progress through the life cycle. Our services do have a life cycle of 12 to 18 months. However, there is no deactivation in START. You can, hit a period of stability, and then that's great. You don't need us so much anymore. Then that participant is deactivated. 6 months later, another crisis comes up. The person can be re-enrolled. What makes us different is we look at the whole person. We are very person-centered, uh, person first, evidence-based, and trauma informed. So we take a really deep dive into the biopsychosocial aspects of a person and pull all of those informational threads together to get as clear a picture as possible. Because a lot of times the people that we work with over the years, you know, end up collecting a litany of diagnoses that really don't speak to what we're actually seeing in real time. So our favorite question here is why? If you're working with START, we should get used to hearing that question because we're going to ask why about just about everything. And that's not to pry, that's not to be intrusive, but the more detail and information we can get about the person we're supporting, the better we can identify gaps. So when we say gaps, that could be a gap in knowledge, it could be a gap in resources, or it could be a gap in services. So if any of the system members see a gap that we can identify, then START will work with linkage and referral to bring those resources, knowledge, services that you need to you. We want to improve the quality of life, not only for the person enrolled, but everybody involved in their care. So here is a quick overview, and I'm keeping this really simple. We will have Q&A at the end for any other specific questions regarding the program itself. So this is what it looks like. We support adults aged 21 or over enrolled in IDD services that are also experiencing mental health or behavioral health challenges. We provide 24/7 crisis consultation. And I want to stop here for a second because when people hear crisis response or mobile crisis, uh, a lot of different ideas come to the fore. What our crisis stabilization, our crisis mobilization, our crisis intervention looks like is we'll get a crisis call any time of the day or evening, overnight, doesn't matter, and we'll respond. We have a 2-hour response time. Why so long? Because we're not a direct care. We are not intervening to stop the crisis. We are not intervening like a mental health screener would to possibly remove that person for further evaluation. Um, we are not going in and doing a two-person takedown. We are completely hands off. What we want to do is we want to come in and help with de-escalation strategies, and we provide a full comprehensive crisis intervention and prevention plan when people are enrolled with us. Uh, that's usually delivered within the first 60 days. It's very comprehensive, and we do speak to what would be a great de-escalation strategy in this situation for this person. And we put together like a whole toolbox of those. So our crisis consultation looks like us coming in, seeing what interventions have been tried, gauging the success of those, or whether or not they need to be changed. And also, a lot of times when a crisis occurs, it could create a fracture in the system. So we want to rejoin the system as well. We want to work through the crisis with you, what happened before it started, what it looked like during, and how we can move forward and have stability, you know, uh, stability I guess, you know, maintained or reestablished. What we don't do is any type of direct intervention, but what we'll do is we'll follow up with the crisis caller, whomever that was, whatever system member called, it could be a caregiver, it could be a provider. We will follow up the next day, check in, and then review all our information. We will update the crisis plan, and we will distribute that and train out on that going forward. Again, everything we said before, it's stabilization planning more than direct crisis intervention. And the more collaboratively we can work with the systems, the better we could hope for long-term support and stability. Who you may work with. START is a whole team. So you would be interacting with most, if not everybody on our team. We have clinical coordinators, and they are the person that is directly responsible for meeting the system, conducting the intake, meeting with the participant, drafting the crisis plan, and working with the systems on a weekly basis. The clinical team lead, they supervise the coordinators. They work with them on their clinical conceptualizations. They work with the coordinators if there are sticking points and how we can work through that to better support you. We also have our clinical director, um, Dr. Jackie Palladino. I'm not sure, Dr. Pay, are you on? She may not be joined yet. So she is our clinical director, and her role is to make sure that any type of intervention or proactive strategies that we put in place are clinically appropriate. So everything, gets funneled through her to make sure that we're clinically on point. We also have therapeutic coaches. Theoretically, we're actually not rolling out therapeutic coaching until later in the year. But what they do is they work with the participant and their system on it could be skills building, it could be increasing socialization in the community, it could be different communication strategies, it could be wanting to explore a creative outlet, anything that could help that person um, build more joy and meaning in their life, or if they're struggling with a specific skill, we're there to support that. The therapeutic coaching it's short term and intense. It's usually about, maybe 10 weeks max, and it's 2 to 3 times a week, 60 to 90 minutes. And as soon as we start coaching, we already have a discharge plan that we're working on to make sure that all of those skills are not only retained, but maintained. And then the community providers and partners. You are our most important resource. You would be working with us collaboratively. You would be, communicating with us even outside of pre-planned meetings. If some new information comes to light, if you have questions, we are always there to support you. And again, the more information we can exchange, the better crisis plan we can put in place. Dr. Palladino?
Thank you. Yes, I think everything that Stephanie said is very helpful, that we had discussed, as well as one of the main pieces that I'm really involved in with the coordinators is helping them develop the clinical conceptualization for our cases. We have things such as clinical consults that we work with our medical director, Dr. Dodge, and she is very helpful to provide additional recommendations, resources, and all of that information that we come together collaboratively to discuss. We will then review with the community partners, providers, the team, caregivers, family members. We're really just working towards building the system's capacity to better support the individual. That's our main goal.
Thank you. Very well said. So again, I mean, it goes back to a team approach within, like within the START program and without, outside of us within the community and the people that we're working with, and hopefully with some of you to support people we care about and help build the best, most peaceful, stable, joyful lives as possible for them. So here are our guiding principles. Um, these are all important. These are with us every day. We live and breathe this. We meet first thing in the morning, every morning. You know, we discuss any, crises calls that came in, and we always come back to these guiding principles. Specifically, and then I'll let Dr. Palladino jump in, strengths-based positive psychology, focusing on what is strong and not what's wrong. Wellness based, that's a big thing for us because people think wellness, great, but that's not just the absence of illness. Wellness is having a full, balanced, meaningful, healthy life. So how do we get people there? We take a deep dive into biopsychosocial. We want to know not just a medical history. We want to know what that person looks like from a social level. We want to investigate any type of psychological or psychiatric components, to their history. And at the end of the day, everything we do is trauma informed. Our goal is to create a sense of safety for that person and for their system. Because when you have safety and you have consistency, those things in itself tend to reduce trauma and they can help interrupt that trauma loop. Dr. Palladino?
Yeah, I would definitely agree with what you said, Stephanie. And I think, as I mentioned previously, our main goal is to really help the system. But we also want to, instead of it just being stability for the individual, it's really focusing on ways that we can help the system and individual best thrive so that they can all live their best life. And what that looks like, that could be different for every person. So that is the reason that we really try to go through this deep dive through the biopsychosocial lens, um, and develop or to look at any additional gaps that may be missed, and then where our supports could be best served, where we can help intervene in those areas.
Thank you, Dr. Palladino. Positive psychology and PERMA. I'm not sure if people are familiar with PERMA. You may be, you may not be, but essentially what it is, it's the entire macrocosm of somebody's life. And how do we improve that? Obviously, you can see it on the screen, positive emotion, engagement, relationships, meaning, and achievement. So that's positive emotion, feeling good, being creative, enhances perseverance. Engagement is, having those deep and meaningful relationships and being when I say relationships, not relationships with people exclusively, but also relationships with, your community, your activities, what puts you in flow. Flow is when we get so wrapped up in something, so involved in something that time just becomes meaningless. We may forget to eat. We may forget to get up and get a glass of water because we're so engrossed in what we're doing and it's bringing us such joy that we just want to continue. Obviously, relationships are a huge part of all of our lives, and we want to cultivate, strong, meaningful relationships, for the people we support. Maybe some people have challenges with maybe expressive or receptive communication. That's something we could work on. Um, Maybe somebody has a history of trauma. So even though they value close relationships, they may be hesitant to form those. We want to foster that. We want to create meaning as part of a purposeful existence, and a sense of achievement because that builds self-belief. There's also a plus at the end, and that's more of taking care of our bodies, proper diet, sleep, exercise, mindfulness practices, and enough sleep and just everything that would make us feel really good. I'm going to hand it over to Dr. Palladino because she's our PERMA expert.
And the one thing that I wanted to say additionally to this, Stephanie, I think you summed it up well, was that this is the area that we really love to collaborate with the participants specifically around. So we have a happiness and leisure assessment that we also are able to complete with the individual that we're supporting to really be able to see and ask them some of the things that would make them happy or things that they would like to incorporate. We want to make sure that the individuals we support are heard. And I oftentimes think that that is missed with this population, unfortunately. And we want them to feel like they have a voice and a say in the services that we provide as well. So we try to incorporate and collaborate with them as well around what that will look like for them and how we can best support as well as get them to thrive in the community.
Thank you, Dr. Palladino. And none of this is static, right? As we evolve as people, all of us, these can change. And the more broad our collection of experiences become, the more we can incorporate different areas of PERMA into the lives of the people we support. Dr. P, do you want to take this one? How START helps?
Sure. So this is sort of a sum of everything that we've already discussed in terms of PERMA, how we can implement that, our trauma-informed approach in care. I think a lot of the individuals that we tend to serve have experienced some type of trauma, whether that's, small t trauma, capital T trauma. In some way, it's impacting them. And we really try to strive for trauma-informed approaches, creating safety for our individuals as well as the system. So what would that look like for, a day program or a group home or even a family home? We try to create safety for that individual and provide strategies to the system to support them the best they can. So we can identify areas where we've seen the individual at their best, and then we can develop everyday supportive strategies that will help the system support the individual.
Thank you. Very
Sure.
well said. So, as important as explaining what START is, it's important to outline what we're not. We are not a replacement for support coordination. We do not supplant direct care services. We are not case management. We are not residential placement. We do not have any residential resources at our disposal. We are not long-term therapy, and we are definitely not one-on-one ABA. Uh, that's actually something we see quite a bit. People hear an IDD service and they already, they seem to equate that with ABA. We're almost the opposite of ABA. We're not collecting any type of functional data. We want empirical evidence on what makes this person thrive versus what may contribute to them not feeling their best. That goes back to what Dr. Palladino said about us getting really granular from the biopsychosocial lens, because the better we know the person and their system of care, the better we can work towards coming up with, proactive strategies that would be meaningful for them. So when to refer to us? Anytime there is a breakdown within the system, placement disruption, day program or pre-voc disruption, uh, if there's a very complex case, maybe there's an issue of, a long list of diagnoses that don't seem right, or polypharmacy, a long list of medications that don't seem to be helping, any type of new or escalating crisis patterns, repeated 911 calls or ER visits, and even caregiver overwhelm. These are all reasons we have had participants referred to us, and they are all, equally valid. And the reason for the referral has no bearing on the services we provide, just on where we start.
Mhm.
How to get to us. If you visit the YAI website, which is yai.org, there's a tab you can click on what we offer. You'll go to Crisis and Behavior Support, Start Services New Jersey, and there you will actually find a link for the Start referral form. You can download it, you can pre-fill it, and then you could submit it right there through the portal. It comes directly to myself, Dr. Palladino, and our administrative assistant, and we will review that and we will get back to you. Actually, I'm going to back up one second. What happens? I'll start it this way. When we receive a referral, we review it. We confirm eligibility of services through the Division of Developmental Disabilities. Once that is established, Dr. Palladino and I will review it. And once we've determined that it's clinically appropriate, within 72 hours of receiving that referral, we will assign it to a clinical coordinator. Once that is assigned to the coordinator, within 24 hours, they will reach out to the referring party to begin setting up the first intake meeting. So here's our criteria. We'd mentioned this before. 21 years of age or older, enrolled in DDD services, you know, also having, a behavioral health concern or a mental health concern, not in need of any type of substance use rehab, And importantly, right now we are only in the 11 southern counties. So we're from Middlesex County south to Cape May. Uh, we hope that we are successful and we can eventually expand statewide, but this is where we are right now. So if you are curious about START and you are within our catchment, we would love to hear from you. We do understand that if you're referring to us, the person that you care for is probably not having a great day. Uh, we understand that and we want to help. Dr. Palladino, did you want to expand on anything I just said regarding the referral process?
The only thing is just that we receive referrals from various different entities. So it could be a support coordination agency, a family member, day program, group home. We the referrals come from all different directions. And then we just verify the eligibility. And then from there, we are able to assign the case as long as they're clinically appropriate. And we really do strive to work hard upfront to get as much documentation that we can, because that then informs our clinical perspective moving forward. So that is another piece that we really work with our administrative assistant on, is getting as much background information that the referring party can provide us with.
Stephanie, Dr. Palladino, if I could ask, if someone is currently in a hospital setting or crisis unit, can you step in and provide support during that time?
If somebody is in that setting, uh, whatever that may look like, and there is an identified discharge date, then yes. And we would like to be a part of that discharge planning process. Um, we'd want to get access to as much information as we can about why this person is where they are and how they got there. And yeah, we can, as long as there is an anticipated discharge date, we could be involved from that point.
Great. I'll let you go on. I apologize. Thank you.
Nope, that's it. Thank
Oh,
you.
oh, I'm
We,
so sorry. So that was perfect timing on my
yeah,
part. There we
it
go.
was. I thought you planned that.
I did not, but that was fabulous. So thank you again for providing this overview. I know that we are starting to hear the Start Services of New Jersey term, right? We're hearing about your supports. I think it's hard for family members to and professionals, right, to have that vision of what does this service actually look like? And so often we're hearing a service where this is really organizing resources to some extent, with that medical component added on. So I think it's a little bit different than what we have as family members have considered to be a support. But it may be that missing piece for some families that, like you said before, are sort of going to bridge that those needed services to come together. And quite often it is that collaboration piece that allows services to be more successful. So we have a tremendous amount of people that have joined this session. So we do have quite a bit of questions coming in. Um, can you just share again, will you go in if someone is in active crisis to try to de-escalate?
We will. However, it looks a little bit different than traditional crisis response. So if somebody is actively in crisis and, you know, we get a call through the crisis line, obviously we'll gather information. Um, the on-call coordinator will then collaborate with their administrator on call uh, to see what that mobilization and outreach would look like for an emergency assessment. We would ascertain for safety, and we would absolutely mobilize to, respond to the crisis, whether that's at a group home, a family home. We can actually call ahead if somebody actually is unfortunately going to a hospital, so we can run interference that way. Usually when the coordinator is responding in person to a crisis, and that is the rule, not the exception. It's not like, oh, well, maybe Star will come out. Nope, we will. If you're calling us, we want to respond. Uh, but then the administrator on call can also uh, help run interference with the person who called the crisis line, like I said, with other providers who may be involved. And yes, as long as it's safe for us to come in because we are hands off, then we absolutely will. Dr. P, anything to add?
No, yeah, we are mobilizing. We have the 2 hour response time, so we're letting everyone know that ahead of time. We will go, we're providing de-escalation strategies, and then we're really working with the systems, like everyone else that's there during the time of crisis, working with them to join the system, rebuild the system. We know that a lot of times, even in the family home, group home, there's some type of disjointing that goes on during a time of crisis. So we really want to be there to debrief with them and also provide additional recommendations to help get through the next 24 hours until we provide our follow-up the next day.
Fabulous. And I think the part that really sounded unique to me when Natalie from CLEP and myself first went to one of your presentations was that you will go into the family home or provider managed settings also. So that's fabulous, right? I think the more support, the better, especially the more support allowing someone to remain healthy and safe in their home, whether that's the family home, a home of their own, or a provider setting, is really key. Can you talk a little bit about unseen medical issues? So if someone is presenting with some unsafe behaviors, is there conversations that happen to make sure unseen, let's example dental issues maybe are being experienced that no one has looked into? Is that part of the conversation?
Absolutely. And that will not only be a part of the conversation if there's a crisis presentation, that'll be a conversation preemptively. That goes back to why are we seeing what we're seeing and what are we not considering that maybe we should be considering, such as uh, dental pain, such as, gastrointestinal issues, uh, such as migraines, especially when we work with people who have challenges, with expressive communication, or even if they don't use language per se, how are they getting that across to us? Because not only are you now in pain, now you can't tell someone you're in pain. So now you're frustrated, and that makes you angry because somebody's trying to help you in a way that you don't need. And that can create that vicious cycle. So the more information we can gather exactly on those things, and it's why we ask a lot of questions, is we can consider that, in the beginning instead of a rule out at the end.
Fabulous. And so I'm going to try to get to some of the questions in the question Q&A section first. We have many questions coming in, being sent to us in the chat feature also. So it was stated that this is not ABA, but how does this work with someone who is already receiving ABA behavioral services within their placement?
Dr. Palladino?
Yeah. So we do work with all members of the system. So this is something that we would incorporate as well. We're not taking away any service, but we're just an additional member to that system. So we're working on systems meetings with as many providers, behavior specialists as possible that are involved with the participant. And we're helping them and getting their feedback as well on what they're noticing, what they're seeing in the home, observations that will help inform our crisis plan, our full crisis plan.
Okay. And how often would you work with the individual, for example, through observation? And how often would your team meet with a support coordinator or behaviorist during this process?
We, all right, two parts of the same
Mhm.
question. When we accept somebody into our services, we automatically assign them an acuity level at a number of 4. So that basically means we'd be meeting weekly. Um, as we continue through our work and the person in the system becomes more stable, we do periodic assessments and that acuity can drop. We do them once a quarter. So we can start out as weekly, then go, you know, bi-weekly, then monthly, then quarterly. And then once we're at quarterly, we watch for another quarter and then we deactivate for stability. As far as how often, that is up to the system. We want to meet with as many people as possible, as consistently as possible, especially in the beginning when we're gathering all of that intake information that we're going to use to develop a provisional crisis plan. And then we're going to do a deeper dive into a longer crisis plan. But listen, some people have big systems, right? And we're all busy. We all have very full calendars. So maybe not everybody is going to make every meeting. And that's completely fine. Uh, More times than not, the primary caregiver and the support coordinator are key. Also, the guardian, if that's, you know, a, an ancillary person. But we would like to have like a full systems meeting, in the beginning, at least monthly.
Fabulous. And so can you talk a little bit more about the funding for your services? We did have someone specifically ask if this is being pulled from the budget.
That's a very good question. It's a valid question. We get it all the time. So the answer to that is no. We, when we won the RFP, YAI for this program, we are under state contract with the division. So we are funded through them. This, we do not bill Medicaid. This does not come out of anybody's budget. It, our services are completely covered by New Jersey DDD. At
Fabulous.
least for now. Like if something changes in the future, that could be different, but there's been no hint of that happening anytime soon.
Fabulous. So there are two parts to the next question. The individual is asking, how might this practically look for someone who is referred to you? Once they're working with a service coordinator, what kind of specific supports do you bring in or offer? In other words, take us through a case study of how this might look.
Well, obviously the referral process goes through, the coordinator is assigned, the coordinator reaches out. We have our systems meetings, we complete a comprehensive intake packet, and we want to really understand what the challenges look like. What is the system seeing? What is the participant experiencing? We want to meet with that participant as well as, their caregivers. We want to see where they live. Uh, we want to ask questions about what their life looks like. And we will follow up, on a weekly basis. Even, obviously we're always available. You can call us at any time. But where we're going to begin is identifying common traits within any type of maybe period of heightened stress or any type of an emotional escalation. Are there similarities like this happens in X environment? Does it happen at this particular point of the day? And the more information we have on that, then we can build uh, intervention strategies as well as proactive strategies. So we'll discuss what to look for when we see that, when do we implement what, and then we reconvene and we discuss, well, how did that work? Was there any result from that? Uh, did we almost hit the mark and maybe miss it? Or are we even using the proactive strategies? And what does that look like going forward? Because if we propose a strategy and it's not comfortable for the system to introduce, well, then we need to reconvene and decide, on a better course of action. Dr. Palladino, I'm going to defer to you.
Yeah, I was gonna jump in as well. So thank you. That's a great question. And it's a very It's a unique question in that for every individual, it will probably look different, like what our service would look like for that participant and their system. So, for example, we do go to appointments with the participants and the system members. So, for example, like psychiatry appointments, we could be there to provide additional support, as long as, there's an ROI sign that we can speak to all of these members of the system. We can go on appointments, provide our insight as well if there's like discrepancies on maybe certain things that maybe the family's seeing that is not being seen in the group home or in the day program. We can certainly speak to that in those appointments. We've also gone and supported our participants at dental appointments that it's been really hard to get them to go. And we've had our coordinators be willing to go out there and help get them into their appointment because that was a big barrier. Um, Also, as well as working closely with a support coordinator, support coordination agencies for additional linkage to resources. So any other services or recommendations, we would work closely with them to help provide to the system as well.
Fabulous. I think right that gives definitely a clearer vision of how this is a very person-centered plan. I'm sure that you're working with each family. It's looking very unique to that individual's situation and the resources that would be beneficial to them. Is this a resource service that will suggest providers that a family or if someone lives in a provider managed setting, that they can reach out to for optional direct supports? So if a family is experiencing, for example, some behavioral challenges that are just unsafe in the home, can you refer out to agencies for that person to have a BCBA come in and provide supports? Or is this not that kind of resource for families?
We can definitely help identify resources. We can also link to providers that we're currently working with through other systems, from our participants. If there is a specific need, we can definitely help identify, organizations, providers, therapists, whatever the person may need. Now, would that be the best fit? Perhaps not. But even if we suggest someone, there's a call between the the caregiver and that provider, and maybe it didn't work. We'll reconvene and say, okay, where was the disconnect? So we could try to find something more tailored to what you specifically need. Obviously, we're not a resource bank, so it's not like Melanie needs a BCBA, so let me just, pull from my workbook of BCBA providers. So it'll be like a collaborative effort in that.
Okay,
Dr. Palladino, am I speaking out of turn?
No, no, definitely not. No, that was accurate.
perfect. And is this something that an FBA or a behavior support plan would be formed with the family? We have someone asking.
I'm not, can you repeat the question? Because I'm not sure if I'm interpreting it correctly.
The individual is asking if an FBA or behavior support plan is this that kind of service? They want to know, it sounds like it's an FBA and then a behavior support plan kind of service, or are they misunderstanding? They want to know.
It is neither of those things. We do not collect any type of empirical data. We do not put anything into a plan that speaks to um, encouraging or, extinguishing any type of behavior. What we want to know is what those instances of challenge look like. We want to identify what the driving factors for those are. And then we want to build in protective and proactive strategies around the person. So hopefully we can intervene before they actually reach crisis level. But we're not trying to influence behavior in a way that ABA will, and listen, they do a wonderful job. That's exactly what they're there for, and it's definitely necessary. We're almost the opposite of that, is that we distill it down to what is making this person tick, what feeds them and nourishes them, and what causes them distress or sadness or grief. And Is that where those challenges are occurring? Dr. Palladino, you're the clinician. I'm
The
gonna
only,
toss it to you.
No, that was accurate, Stephanie. I think the only thing as well is that so again, we're not replacing any type of service. So we work closely with BCBAs if they are a part of that individual system. And when they're developing their behavior support plans and when we are developing our full crisis plan, we collaborate with each other so that we're not saying things that are completely different than the behavior support plan and vice versa. So we want it to be a collaborative process. So we are still working with them very closely for what they're seeing and then what we're seeing as well in a clinical lens.
Fabulous. I think complementing, right?
Hmm.
You're sort of complementing each other, and that's a big piece, right? So often it's not one or the other. It's having those conversations with everyone at the table that can make a difference. So, for example, my son does live in a provider managed setting, and he has some very complex needs at times in his life, also has many beautiful skills and abilities. Um, but we know that his presentation and his interest and challenges are all different in different environments. And it really has shown that, by us forming those collaborations with the people that know him best in these other environments that show what brings him the most happiness and joy, and what situations may be extra stressful for him and what works in each of those environments. Um, Getting his input as much as we can also. But having us all work together definitely has shown greater success than not. So it sounds like you're able to complement the existing team to find additional
Hmm.
resources to really, right? Um, it's not a this or a that quite often, right? We're blending models that will work together. So
Beautifully said. Exactly.
good.
We want to collaborate and we want to consult. Uh, we're not there to do anything other than that and to try to get the answers that'll be beneficial for the system and definitely for the participant.
And I think Stephanie and Dr. Palladino, you said something that was really impactful before. You were sharing that if you're offering these proactive strategies, right, and someone's not comfortable implementing these strategies, those strategies are not going to be effective, right? So really working with the whole team to see what's going to work, obviously for that individual, what they're going to be comfortable with, but working with the people who are supporting them in these various environments to make sure that consistency, I'm sure, is going to be key in this process also. Um, and everything is about choice here, right? This is nothing that someone has to continue with. It's something that someone can explore and continue with, or say, hey, it's just not the right fit at the right time. So is that accurate also?
It is. We are 100% voluntary service. And START is a very unique model. It might not be the perfect fit. It won't be the perfect fit for everyone, but a lot of times people, even sitting through a webinar, even sitting through several webinars, have an idea of what the service looks like theoretically. And then when it comes to practice, where the rubber meets the road, it may not be what they're looking for. Uh, because you know what? A lot of times, you know, there may be some uncomfortable conversations like around, hey, this doesn't seem to be working. Maybe we could try this instead. But when you've been executing A for decades and now somebody's saying maybe we should try B, that could be potentially uncomfortable, right? So we want to make sure that everybody is on the same page and understands the rationale for any suggestions or interventions that we're making. And listen, this is definitely a democracy. We have to have it work for everybody, otherwise it won't be used, and then there's no utility in that.
So I'm trying to consolidate some of these questions because there are so many. So can you talk a little bit, remind us again, anyone involved within this person's care can provide make that initial call. Is that correct?
Yes,
Okay, perfect.
And
And
Dr. Palladino, I'm sorry, you had something to add? I think we jumped ahead of you.
that was okay. I want to make sure that we do have time to get to the questions. I can save my little last tidbit for at the end.
do you have ability for translation services also for families, parents, or professionals who English is not the first language?
We don't have anything formal yet. We are actually working on like a TTY type of service. But when we have that situation come up, we honestly use phone speakers and Google Translate in conversation mode.
Okay. Um, can you talk to me a little bit about if a individual is living in a provider managed setting? Um, would that group home, if a family wants to make the initial call, the group home would have to be in agreement to have this service. Is that correct?
Yes and no. Honestly, it's up to, well, I mean, if we want to get down to legalese, it's the guardian who makes that call. Uh, of course, if somebody's in a provider managed setting, or a congregate care setting, if we don't have the buy-in of that organization, then start work is going to hit a roadblock. Especially since they're providing the majority of the care for this person. We want them involved. We want their engagement because you know what? They're going to be the best resource we have for getting information on what this looks like on the day to day. So typically, knock wood, um, we have not found that to be an issue. Sometimes getting together and connecting might be a little bit challenging, but I have yet to see a residential provider say, no, absolutely not. We're not going to be involved with that.
Let's see. Will this service advocate for supports they believe that may be needed? For instance, if it is believed that someone is in need of a one-to-one support but doesn't have the budget for that, can this program help with that advocacy?
Yes, I mean, we would definitely take, all of that into account. We would speak with the support coordinator, but more than that, it's not just sheer, like pure advocacy. It's, evidentiary information. Like, this is what we have seen. This is what has been reported. This is what has been experienced by history. We really think a one-to-one in X, Y, and Z setting would be appropriate. What are your thoughts? What are the options for maybe doing a reassessment, redoing the NJCAT? If that's an absolute no-go, this can't happen, well, then let's work together within the person's budget and what's already, budgeted for, what other services there are there, and see how we can implement or augment, maybe to get the more personalized support. And if, there are always resources like outside of the person's direct budget that we can investigate if need be. But yeah, I mean, we can definitely advocate, especially when somebody really needs that extra level of support. Dr. Palladino?
No, in that question, I think you answered it perfectly, Stephanie.
Again, I'm trying to group a lot of these together. Again, anyone can make that initial call. Stephanie, do you want to put up the number that they would reach out to?
It is actually well, the crisis line number is only distributed once the person is enrolled.
Okay.
So if you go to the website, yai.org, and click on the What We Offer tab, under Crisis and Behavior Support, you will see Start Services New Jersey. And that's where you will find, like a little one-page blurb about our services and like an overview of what that looks like, as well as a link to the referral form that you can complete and then submit right through the portal on the YAI website. And yes, anybody can make that referral.
Perfect. Give me just 1 second, everyone. I want to say, or Stephanie or Dr. Palladino, can you drop that link into the chat section if possible? Just one second, everyone. I want to make sure. So what we offer, and we're going to go down to, is it crisis and behavior support?
Yes.
Okay,
I'm trying to see if I can get the actual link to drop in the chat.
sure. And I am doing the same. I want people to have what they need leaving this. So,
Absolutely. Let's see. There we go.
perfect.
Oh,
Thank you
same
so
one.
much. I appreciate that. And let me just take up, thank you, Colleen. Um, Colleen added that also. So
Yes.
perfect. So let me just look through the chat section one more time. Every time someone adds something else, it's moving up. We have a lot of compliments coming in, compliments from BCBAs saying that this service is needed to bridge. Families absolutely can contact. I think you went through step by step already, what that would look like possibly for a family depending on their needs. And can you talk a little bit, one of the things is you did mention trauma before and the big T and a little t. And I know you and I had that conversation when we were first discussing the webinar. And that's the big T and little t. Can you talk a little bit more about that?
I am going to
Yeah.
defer to Dr. Palladino for that. That
Okay.
is her wheelhouse.
Sure. So I mean, when we're thinking about like big T trauma, we are more so referring to things that are related to like physical or sexual abuse, kind of those overarching things. But I mean, little T trauma it's more subjective to the person, right? We can't necessarily say whether something was traumatic to someone or not, and it's more of that perceived experience. So we're thinking about it could be like a certain transition. It could be whether someone suddenly left a part of their system, whether that's abandonment. It could be many things that we're referring to as little t. And I don't necessarily those are just like a way of categorizing it. But as I mentioned, we are a very trauma-informed approach. And this kind of gets into one other piece that I wanted to mention. I just want to throw this last little tidbit in
Please.
that we're working on providing oxygen for the system. So I know a lot of times when the system can be very overwhelmed with, the behaviors or challengings that they are faced with every day from, the participant. But one of the things that we do is really providing oxygen. So I've been told this from, families that we've worked with, that they get tired of having to explain and go through and run through the long list of things that have come up. And part of our crisis plan, our full crisis plan, is it includes things like strengths and interests and skills and when the individual is at their best. So it's not all about these negative, bad experiences or behaviors, but also the strengths of that individual. They have strengths and skills and interests, and we need to make sure that we're capitalizing on that to best support. So we want to make sure that that's one of the things that we start with when we're trying to bridge the gap and communicate with the system.
Dr. Palladino, I love that you brought that up, right? The club team yesterday was in a room with family members and community providers together. And we had the pleasure of speaking about not only what is important for someone, how someone needs and wants to be supported in their life, but we take a very strong focus here at Club to speak about, right, what people like and admire about that person and what brings that person happiness and joy, right? What's important to them to have in their life. Because without those components, right, people are not going to be happy. And when they're not happy, that leads to unhealthier
Mhm.
behavioral outcomes quite often. So I'm thrilled to hear that you're taking that approach. And I think when we did have a couple of questions about people who cannot communicate verbally. I would assume that you're relying on the people that know that person best and know how that person communicates their wants and their needs and their feelings, so that person's voice is also collected during this process. Is that correct?
Yes, that's accurate.
It is accurate. And then
Mhm.
we can also work with the system if we need something like maybe introducing like an emotion chart or a pain chart or a PEC deck or any type of ACD, and that could be a discussion later on. But yes, we would defer to their primary caregivers in the beginning.
And I think just quickly before moving on from that trauma, as a family members, we hear the word trauma. And so often as a community, we think those big T's that
Mhm.
you briefly described, Dr. Palladino. And for people with intellectual developmental disabilities, it's almost safe to assume that everyone has experienced trauma at some
Mhm.
point in their life, whether we have seen that trauma occur or not. And I think that's a really valuable point um, for everyone to consider. So these positive approaches um, are are absolutely right, going to complement those traditional resources that maybe families are already tapped into. And can we get to two more questions before we say goodbye? I know we're a few minutes over. Um, can you talk about if you provide this support outside of individuals who do not have a DDD eligibility?
Start services does not. One of the eligibility requirements is enrollment in DDD services.
Okay.
However, if you were to, outreach to us, if you were to call the office, uh, and you had a specific question about, that unique situation for you and ask for resources, we could try to help as best we can. We just wouldn't be able to enroll that person in service.
Fabulous. And we do have someone asking about the YAI stabilization homes. Is that that is a different program through YAI? That is not
Mhm.
your program, correct?
Completely different program, yes.
So we would absolutely suggest that person reach out, explore the YAI's website, that yai.org. Is that correct?
Yes, you will
Fabulous.
definitely find links and resources specifically for the stabilization homes.
Fabulous. Love that. And absolutely, if that's a consideration that your family may need, reach out to your support coordinator for that guidance and support also. This recording of this webinar will be available, hopefully within the next few days, but I will promise you by early next week at the latest, everyone will receive a copy of this. If you have specific questions, Stephanie, can you put up your contact information for people to reach out to? Perfect. So there's Stephanie's email. And we will make sure to answer any questions that come our way. By all means, Dr. Palladino, I also want to thank you for participating so greatly in this in today's session. And Stephanie, can you just forward the slide?
I sure can.
Thanks. So just real quick, this is if you are interested in learning about more virtual learning sessions, such as today's webinar, please take a quick shot of that QR code on a screen. That is for the Rutgers Community Living Education Projects. Um, email newsletter and special announcements. You'll receive those emails about upcoming information sessions and any resources that we can provide you also will be in those emails. On the screen, you're also going to see our contact number on the top left corner and all of our team's emails. If you need to reach out to the Community Living Education Project, all of our supports are free of charge also. And Stephanie, one more slide I think we may have. Perfect. So as we were preparing to say goodbye today, I do want to start by again thanking Stephanie. It's been fabulous. I'm happy that our team was able to meet you previously and saw a need to better get out the word that of the services that the START services of New Jersey could offer to the families. Dr. Palladino, thank you so much for joining us and adding to today's conversation. As we're
Thank you.
saying goodbye, you're going to see a quick QR code or a link bringing you directly to a short evaluation. Please take just a few seconds to complete that. It's the information that you provide to us that allows us to better serve you in the community on future topics. So, want to thank everyone for joining. Stephanie, Dr. Palladino, any closing words?
Thank you so much for the opportunity to spend part of the afternoon with you and to get the word about the START program out. I really appreciate the invitation. And, if anybody has any questions, you have our contact information, please don't hesitate. And yeah, perhaps we will cross paths in the future.
Perfect.
Thank you so much for your time.
Thank you. Thank you, Dr. Palladino. Stephanie, can you just go back to your contact information just one more time and we'll make sure that that's our closing
Absolutely.
slide. Perfect. Thank you, everyone. Please be well. We look forward to seeing you in the future and have a great day. Enjoy the summer.
Thank you. You
Thank you.
too.
Be
Bye,
well.
everyone.